Okay, reviewing IM injections. So, got your gloves, got your goggles. Your patient is in complete distress, and we're going to do our best to explain what we're doing as we go through. First thing we're going to do is pick our site, clean our site. So, with the deltoid, remember, find the bony part of the acromion process, and then go down about 2 finger widths below the process. You can make your arm or your finger across here and make a triangle, and then just aim right for the middle right there. And we'll clean from the center out. We'll let that dry. Then we check our medication and, of course, patient, medication, dose, route, time, expiration, allergies, contraindications, color, clarity of our medicine. And with this patient, we need to make sure that he is under 50, has no cardiac history, and has a pulse rate of below 150. And if those things are present, we need to call medical control to get permission. All right, so we have our vial of epinephrine. It's been checked over okay. It has been used before, so we have to disinfect the top of it if it's not a brand new one. We're going to use our IM syringe, which is the 1.0 milliliter syringe. And the appropriate needle for this is the 1.5 inch needle, 20 to 22 gauge needle. So we'll switch that out so we have the right size needle on there. So we have the larger needle for the IM injection. So we take our epi, and first thing we do is we find our dose. So our dose for epi for the adult, 0.3 milligrams. Pull back our syringe to at least 0.3. Turn the bottle upside down, insert the needle, and then push in the amount of air you want to pull out. Pull back 0.3. I like to go a little bit more, maybe 0.4. With the needle still pointing upwards, you can tap the syringe to move the air bubbles to the top, and then you can also advance the syringe to move the bubbles up through the plunger, and then set your plunger at 0.3 milliliters there. So now we're ready to inject our medicine. We're going to go back to our spot, which is clean and sterile. And we can hold the skin or stretch the flesh a little bit on either side of the injection side. And then we insert the needle, again putting the bevel up as shown, and it's shown to be less painful. So we find our spot, bevel up, a quick insertion, and then immediately we stabilize the syringe after that. We aspirate back shortly to see if there's any blood. If there's no blood in the syringe, then we can go ahead and depress the syringe down and then pull it away immediately. And you will fail every test at this point if you do not dump that syringe in the sharps container. Then we can take two clean fingers massaging the site, and we can place a Band-Aid over it. And then the last thing we need to do is document, again, patient's name, the medication, the dose, the route, the time we gave it, the name of the medical director or protocol driven, and your name as the EMT. And then we would reevaluate all those things, redocument those things, and if we need to repeat a dose, we would call medical control. Okay, just differentiating allergic reactions between mild and severe. Some of your signs and symptoms of a mild reaction: some flushing of the skin, you'd have some hives, you'd have some itching of the skin, you would have a normal blood pressure, you'd have no respiratory involvement. Oftentimes this is called a localized reaction. And overall it's pretty minor. Treatment is an EMT, oxygen, monitor the vital signs. If you do transport, cold packs are always good for comfort and pain. Keep in mind, ALS, a lot of times these patients, if they have a history or if not, they go south very quickly, and ALS is a great thing to keep in mind. So the moderate to severe allergic reaction patient, the dermatological stuff or the skin stuff, the hives, the flushing, the itching, they're usually present in a moderate case, but as the patient gets more severe, you might not see those symptoms. So don't rely completely on visual stuff. As the patient's perfusion gets worse, they might disappear. So what we're also looking at seeing in our patient, we would have some dyspnea, we would have some wheezing, and we might have some chest tightness. And those are all pretty moderate signs of an allergic reaction. As things progress worse and the patient either presents worse, we might also have some hypoxia, low blood pressure, and then again, as things either present really bad or get worse, your patient might also have some nausea, some vomiting. They might also have some altered mental status. They might have weak pulses. Little to little air movement. So your patient in a severe allergic reaction could present with all of those symptoms. They could present with some of them. They could start with dyspnea and wheezing and progress to hypoxia, low blood pressure, nausea, vomiting, altered mental status, etc. Now, treatment. So a true anaphylactic reaction, one that deals with low blood pressure and altered level of consciousness, that is a life threat, and that person gets oxygen immediately and epi IM 0.3 milligrams. You're trained on how to do that. So in a scenario case, if your patient presents with an allergic reaction that you find to have a low blood pressure and an altered level of consciousness, you can give them oxygen and start drawing up your epi right away. All of these cases in the severe reaction, it is acceptable to draw up your epi right away and administer it. Now, if you were to have a severe case of a reaction and your patient might have some wheezing, tightness, difficulty breathing, maybe some nausea, vomiting, maybe some hypoxia, maybe that's all they're presenting. For this severe type case, it's okay to do the O2 and then give your epi also. I don't want you to just think anaphylactic reaction is the only thing that you can give epi for. It is also for a severe case of allergic reactions. And I'm completely aware that on your patient assessment grids that it shows that treatment for a reaction like this is all the way down in your history taking monitoring devices secondary when it talks about initiating your management plan. This case right here, an anaphylactic reaction, is something that is a life threat, and this is something that can be dealt with in your primary assessment. Once you do your ABCs and your field impression of anaphylactics, this patient in the field needs to be treated with epi immediately. We don't have time to do all those other OPQRST sample histories like the grid wants. While there are some important things in there that we do need to have, this is one of those cases, again, for an anaphylactic reaction that we need to fix and treat immediately. This patient, if we wait 5 minutes after we get on scene to treat an anaphylactic reaction, most likely this patient will be in cardiac arrest or near cardiac arrest at that time. Just a little bit more on the breathing component here. If you assess end tidal in this patient, you would probably see your shark fin tracing, and your respiratory rate would be higher, so your end tidal might be a little low. Breath sounds might have an audible wheeze, which means that you can hear the wheezing as you walk into the room. You don't need your stethoscope. It might have little to no air movement, which is a really bad sign. On your assessment, they might be tripoding. They might just be fatigued. They might have a low O2 sat. If you are going to give this patient epi, which is totally fine, and you have audible wheezing, it is totally acceptable to give this patient albuterol. And no atropine is given on this patient. So it's totally fine to give epi plus an albuterol treatment, which is your 6 liters per minute normal neb mask. No atropine is needed. It's totally fine to give the epi plus the albuterol. And as you do your, we'll just say, ongoing of this patient or a repeat assessment after you give your epi, you would of course check your breath sounds, and if you still have a wheeze, you can just give albuterol. Do not need to give atropine. And you would hopefully have a normal blood pressure. Your end tidal would probably normalize. And at this point, you would just continue to do your albuterol treatment and oxygen en route to the hospital. I can't say this enough. Anytime you give any medication, whether it's epi or albuterol treatment, as an ongoing assessment, please don't forget these things. I know that anaphylactics is a life threat and you need to get that epi drawn up, and maybe you don't have time to give all these things, but don't forget all these patient rights and documentation stuff, because they all count towards points in the overall scheme of things. But if I ever see you in the field and you're going to give epi to a patient, I would hope that you don't waste time and remember all this stuff. Just give the epi, save the life, and then document creatively later.